having that going on. So, well, we'll go ahead and get started, and then obviously people can join in. And just for those of you who are on here, we also are recording this, so we will be sending it out after, so you'll be able to share it with your teams, your families, your region and whatnot. So. But again, thank you so much for joining. We're excited to continue our webinar series with our partners at Cedars, Sinai, Kerlan, Jobe. And today we have Dr. Tracy Zaslow, and if you were on with before with Dr. Mendelbaum, Dr. Zaslow is just in that same category with Dr. Mendelbaum. She is not only a sports medicine physician, orthopedic and pediatrician. She is the team physician for Angel City Football Club, the LA Galaxy, and she is a consultant for the Los Angeles Ballet Company. She does have 2 children that play AYSO currently, and she is an athlete herself, so she has played all but soccer, hilariously enough, but she is very much focused on the acute care and overuse injuries of young athletes. So definitely our AYSO players. And so she is going to go through all this. Specifically is focused in the female athlete range, but this is applicable across the board. We are going to hold questions to the end, and if you can put your questions in the Q&A box, we'll be able to get to those at the end of her presentation. But thank you so much, Dr. Zaslow, for being with us, and I am going to hand it over to you to educate us. And again, like I said earlier, I wish I would have known some of this before my 3 ACL reconstructions in my life. So, but again, thank you so much, and I will give it over to you.
All right. Well, thank you so much for having me here today. I think this is a great topic. In a short time, we'll try to cover as much as we can about the female athlete. So I will dive right in. So I have no disclosures. And so just kind of to go over a few soccer stats. There's over 300 million soccer players that participate globally, so across the world. Soccer is the 3rd most popular sport in the US with 13 million participants. And when we look at high school soccer and kind of how that breaks down, there's still a little skewing of a little bit more male than female, but coming pretty close, about 50% spread. And when we get to the professional level, it's a little bit less. Female representation is about 21.4%. This is a picture of Angel City FC. So they had a great first season, and excited to watch the women's soccer league really continue to grow. When we see, well, where does soccer fall in injury-wise compared to other sports? And unfortunately, it gets the #1 category here. So for women's soccer, they're the highest injury rate for any women's sport. When you look at men's sports, men's football, wrestling, and soccer do beat out women's soccer for injury rate, but it is a prize we'd like to change. So then looking at musculoskeletal injury rates, just kind of comparing to different gender and what we see. And in females, we tend to see more joint injuries, more ankle and knee, whereas males, it's more thigh injury, like muscle strains, hamstring strains, quadricep strains. So different type of rehab, different type of treatment protocol that we're going to go through for that. And then on your right, you'll see the different injury rates from a number of different kind of league comparisons. So again, interesting to look at the NBA, so men's basketball compared to the women's basketball league. Women have a higher injury rate, and same thing in the high school population. Interestingly, in the NCAA, so college level sports, males do have a little bit more injury than females, and that may just be the high number of football athletes compared to the female athletes. But so it's some interesting numbers to look at. Then we look specifically at ACL injuries in soccer. And again, girls soccer gets to be #1. So they have the highest incidence rate per athletic exposure, so per time on the field, compared to boys soccer, which is about kind of midway through the breakdown. And other runners up are boys football, girls basketball, girls gymnastics, boys lacrosse, girls lacrosse. So really any sport that has any cutting type maneuvers is at risk, but girls soccer comes in first. And we see this again. This is one of the U.S. national teams, women's teams, and all those who are circled had a previous ACL reconstruction, at least one. So like Yvonne, who did the wonderful introduction, many have had multiple ACL reconstructions. And so this is partly why we're here today. And so we'll talk a little bit more about ACL background. What is the ACL? How is it injured? Go through the treatment protocols, and my big kind of honing point is how do we prevent it? And so there's a lot that you can do as parents, as coaches, and so we'll emphasize a lot of that today. Also talk just a little bit about concussions and then overall benefit of participation in sports. So we will dive right in. So I'm sure everyone knows ACL, if like the term is always thrown around, but what is the ACL? So ACL stands for anterior cruciate ligament. And so it's a ligament that connects the femur bone, the thigh bone, to the tibia or shin bone. And it's a really important ligament for stability in the knee. So it's what really prevents shifting of the knee from front to back, and it also limits knee rotation. So when it's torn, we have an extremely unstable knee, and that's where the issues come in. So when we look specifically at the ACL, what age groups are most at risk? And that's really our kind of 15 to 19-year-olds, and 2024, that range of 15 to 25 is really the main age range. It may be in part because that's one of the highest age group that participates in pivoting sports, but there's probably also some biomechanics issues that with growing and changing at that time. And so it's definitely the target population that seems to have the highest rate of injury. Female athletes, again, have, depending on which study you look at, 4 to 6 to even more times higher risk than males for ACL. And again, looking at high school athletes, we see girls soccer more than boys soccer, girls basketball more than boys basketball, and girls softball more than boys baseball. So it's a lot of injury in that female athlete, which is why we're focusing on it today. Additionally, looking at children. So does ACL injury happen in children? And the answer is yes. This diagram that kind of shows the trend, this increasing trend of about 148% over a 10-year period from 2005 to 2015. And in this study, it was really only looking at the 5 to 14-year-old range, and it was the upper end of that range, 10 to 14-year-olds that had the most injuries. So your 5 to 9, 5 to 10-year-olds are pretty, are much less likely to have the injury, but 10 to 14, the rate goes up a lot. And so why do kids get, why are we having more ACL injuries over the past few decades? So number one is probably the number of children participating in organized sports. And that participation is a lot more intense. They're starting earlier, they're doing more practices per week, more hours per day, and more intense when they're on the field. Additionally, we have better awareness. I think, decades ago, we didn't really think kids would get ACL tears. We said, oh, kids break bones, they don't tear ligaments. But unfortunately, kids do tear the ACL. And now with better MRI imaging techniques and availability, we're just diagnosing it a lot more. So what do we do when the ACL is torn? There's really two options. You can have surgery, or you can choose not to have surgery. So what are the statistics? If you don't have surgery, how will you feel in life? And it's been shown about 75% of people who don't have surgery will have a lax knee, will have a loose feeling knee. So they'll feel unstable when they're trying to cut or change directions in sports. And they'll also have a 12 times more likely to have a meniscal tear. So meniscus is the cartilage that's in the knee. And so you can kind of think about it, if the ligament is torn and you're just having more motion of the two bones on each other, the cartilage that's supposed to be the padding in between the bones is going to just get broken down over time. And so those are really the risks of not having surgery. Those who have surgery can actually do pretty well. When we look at return to play for pro soccer players, it's about 72% can get to that level of play. But amongst your average athlete, it's probably much higher than that. So we do know that surgery can be successful. But we had to go through a little learning process for surgery. It used to be that what was done for ACL was called repair. So meaning you have the two torn pieces, you try to sew them back together. And when you just try to sew them together, there's about 50 to 90% failure rate, meaning that it will tear again. So repair had kind of gone out the window, and it was replaced by reconstruction. So reconstruction is when you use something else to replace the ligament. So what the surgeon will do is to go in, they remove the old ACL that was torn, and they take either a piece of your patellar, I'm sorry about that, a piece of the patellar tendon, or they'll use a hamstring tendon or even a tendon from a cadaver, and they'll drill holes and run the new ligament through the spots where the ACL used to be attached, and have healing and go through rehabilitation and get back to play. So this is great for adults. It's been very successful, but it's a bigger challenge with kids. So kids have growth plates. Growth plates are where you get the growth, bones get longer. And so in this x-ray here, these black lines are where the growth plates are. And so this is a femur bone here. This is a tibia. This is a side view of the same thing. So you have these growth areas, and they're very fragile. So if we do the traditional adult technique where you drill through the bone, you drill right through the growth plates. And that can cause the growth plate to stop growing. So for kids, that's a really big deal, because now you end up with one leg longer than the other, and that's not a good outcome from the procedure. So there's been a few other techniques that they tried. This one where they go outside of the growth plates, so they call it extraphyseal because it's outside the growth plates. This one is kind of below or in between the growth plates, and neither one of them are super great. So we're still looking for other options for what we do for these kids who are still growing but have an ACL tear. And so there's been a lot of research lately into, can we make repair better? So again, we used to just repair by having these, sewing these two pieces back together, which wasn't so great. But now there's a procedure called the BEAR, a Bridge Enhanced ACL Repair, and it's where they use a scaffolding of different factors that help promote growth. And what happens is that ligament can fill in this gap and restore the normal ACL. So you say, well, it sounds great. How's it working? Well, Dr. Natasha Trentacosta, one of the members of our group, is one of the leaders in some of this research and has done many of the procedures. And it's shown to be pretty successful so far. So this is the old technique where they used to repair. And so obviously this is a high failure rate. These green are some of the procedures that were the reconstruction. So they weren't repairing, it was reconstruction. So they had pretty low failure rates. But now, so far, the studies are very small, but so far it appears that these last two columns here where it says BEAR 2 ACLR and BEAR 2 BEAR, these two have shown some really promising numbers that the failure rates in adolescents have been very low. So meaning that ACL does not re-tear with this procedure. So still early, but looking like a really promising procedure. So now we go into, well, what are the risk factors? What makes the ACL at risk for tear? And there are a lot, and every single ACL that happens probably has a different combination of all of these factors. So I'll just kind of go quickly through anatomy, the kind of positioning of the bones, the ligaments themselves vary from person to person, and definitely male to female. It's different genetics, different environment, turf versus a grass field versus what quality of grass field that is, hormonal changes. When there's higher estrogen levels, you can have a little bit of temporary laxity so looseness to the ligament. Does that kind of predispose the athletes depending on the timing of their cycle? And then medical training resources. Do the athletes have the ability to have coaching and trainers to really look at their movement patterns and such? But the part where we're really going to focus on today is biomechanics. This is where there's really a lot of research, a lot of evidence-based medicine. And this is also where we can really work to prevent. So making changes that make a difference for these kids. So just to take a step back, since we're going to talk about biomechanics, we need to understand, how did the ACL get injured in the first place? So there's two main categories. It's contact and non-contact. So you can see here under contact, this is when there's another player comes, they hit the knee, they physically cause a trauma to the knee that is going to strain the ACL and cause it to be tear. Those are tough to prevent. That's, maybe we change the style of the game. These are much more difficult to prevent, but non-contact are very preventable. So this athlete here demonstrates what some of the issue is, and we'll go into it a little bit more, but you can see she has her leg here as she's changing direction. Her foot is planted here, but her whole body and body weight are really central here. She's about to kick. And so this is a lot of pressure on the knee. And it's not a position where the muscles can do a lot to help support the knee. So it really is the ACL, the ligament is the only thing to hold on, and it's only so strong. So this is really preventable because we can change this. And so you say, well, how many are non-contact? Well, there was a great study that looked at this very in depth and found about 88% are non-contact. So that means that we have a big area of ACL injuries that we can prevent. Most of those occur with deceleration, so slowing down, cutting or changing directions or landing. And it's oftentimes in face of being tackled. So they might not actually have any contact with the other player, but they're moving out of the way or changing their gait to avoid another player. And that's where they're at risk. So we really need to work on the biomechanics in that positioning. So what does that look like? Well, first, I kind of mentioned a little bit of the anatomical components. One is just that that females do seem to have a little bit more laxity, meaning looseness of the ligaments than males when they do studies just measuring the movement or the looseness of the ligament. Number two is females have less muscle strength and endurance. So what that means is around the knee, the muscles are not as strong and they fatigue faster. And so that again puts the ligament at risk because then it's only the ligament holding on. They don't have the support of the muscles. And the last point to emphasize today is the strength or the ability to generate torque in the hamstring muscle. So the hamstring in the back of the leg, you need that to stabilize the knee so that it doesn't just shift forward with a movement. And so all of this we can work on so that we end up on this side, the correct side. So when this is showing a step or a landing where the knee is coming forward over the toes, you can see the body weight is pretty well distributed with the forces coming straight down through that knee and foot, versus this side where you can see the foot is kind of one way, the knee is going that way, so the forces are going here. So we call this knee valgus, when the knee kind of collapses in, and I'll show you some more pictures here. So you'll see this person doing a jump right now. So she's jumping from a box down, and you can see as she comes down, her knees just collapse in. I mean, they virtually touch one another. That is not the biomechanics that we want. So what we're really looking for in a landing is more like this. So you can see the knees coming straight forward over the toes. There's no collapse in. Again, here's the collapse on the bad side here. So this is where we target our prevention. And so what can female athletes do? They can do a specific training modality to really kind of integrate this muscle strength and movement patterns to make a difference. And this is a demonstration here of an athlete before an intervention, before a prevention program. And you can see her knee is just falling in this collapse here. Her hip is dropping, and that just puts all the forces in the wrong places. Whereas here, she lands, the knee is going forward here. She's got a neutral pelvis, her hip's not dropping. And this is what our goal is. So that's what we're going to talk about next. So there's a ton of programs that have been developed to prevent ACL injury. And so when you look across the board, there's just a ton of different studies looking at all different programs that all incorporate a lot of the same pieces of biomechanics training, muscle training, as well as movement patterns. And so they show about 60 to 89% success, which is decent, not too bad, depending on which program you choose. And so we're going to focus on the FIFA 11 program because that one, it's most specific to our soccer players. Number two, they have both the young adult to adult version, the FIFA 11 plus, and also they have a kids version, which is for the 7 to 13-year-olds. And this is a program of, they used to call it FIFA 11, but then they added more exercises. So it's up to about 15 exercises that are to be performed about twice a week in practices. And if you do perform them twice a week in practices, it's been shown that it decreases injury rates by about 30 to 50%. So looking a little bit more closely at that in the younger population, so using the younger group of 7 to 13-year-olds with a mean age of 10, those who did the program twice a week and did the full program twice a week were able to decrease their injury rate by about 48%. However, another study came out, which was very interesting, maybe discouraging, but I think really brought out a really good point. So this study showed that by implementing the FIFA 11 injury program in these high school teams, they actually didn't reduce their injury. But then when you kind of tease out the details, about 62% of the coaches in this study reported that their teams did the program more than once a week, more than or equal to once a week. But only 32% showed that they did it twice a week. And so this was a really good study for us to understand that if you don't do the program, it doesn't work. So you really do need to do it that multiple times a week. And this was another set of studies that was interesting. So if you look at these bars, the blue is how often they were doing the program, how often they were doing FIFA 11. And so compliance wise, this tall bar here is those who did it more than 40 times within the season, compared to these guys only did it 1 to 19 times per season. The red line is the injury rate. So you can see those that only did it in this low category, less than 20 times in the season, had a much higher injury rate than those who had been very compliant and done it more than 40 times in the season. So the whole point is just do it. We got to do the program and it makes a difference. And what else does it help with? So we've shown that it helps with injuries, but it also helps with winning. So if you look at this chart here, red is those who did FIFA 11 plus, and the blue is those who did not. And the people who did, the teams that did FIFA 11 plus won more, they lost less, they tied about the same. So so doing the FIFA 11, leads to more wins, which is what everyone's goal is here. Just kind of to sum it up, the average decrease when you look at it across, specifically FIFA 11 plus, when you look at it across multiple studies, is it makes a difference of improving your injury profile by about 53%. So definitely a really good positive. And so we want to use this data to motivate change. We know now we have the information that by doing the program, doing it well, doing it twice a week, that we can lower injury rates, we can have more wins and less losses. I'm sorry, yes, more wins and less losses, decrease time lost from play, and improve biomechanics that will just help in life, as well as preventing ACL tears. So with that, we'll kind of change gears here to talk a little bit about concussions. So how do women fare here? How do females fare with concussions? And unfortunately, they also have worse luck on the concussion side. So concussion rates in girls are higher than boys, and even repeat concussions. So girls had a higher proportion of recurrent concussions than boys did, so meaning more than one. And then when you look at the different rates of concussion, soccer is one of your top. So I have the red arrow here pointing towards girls soccer, but all the ones in pink are the girls sports. And unfortunately, they're pretty competitive here on their concussion rates with other sports. Boys hockey, football did kind of beat them out for some, but girls soccer is one of the highest. Girls field hockey was probably the #1 in this study, but depending which study you look at, girls soccer seems to end up in the top 3. So just to kind of review what happens with a concussion, or what is a concussion. So a concussion is a mild traumatic brain injury. And so what happens is you get hit in the head, or even just have a quick movement of the head, and the brain accelerates in the skull. And when it accelerates, there's changes that happen at the cellular level of the brain. And the best way to think of it is like a computer that crashes and it's got a reboot. If you look at it, if you do a CT or an MRI and it's quote unquote just a concussion, there's not going to be bleeding, there's not going to be swelling. The CT or the MRI are going to look normal, but the function is not working right. There's symptoms, and the brain is just not processing information as well as it could. So This is where we want to really be able to notice it and figure out who has a concussion. So how can you tell if your athlete has a concussion? Well, sometimes it's easy. It's just like picking out the spoon from the forks, but it's oftentimes more like this, where you're looking for this little cat in with the prairie dogs. The set of symptoms is pretty broad, and I'm not going to go through all of them today, but there's 4 different big categories of physical symptoms like headache, nausea, vomiting, balance problems, sensitivity to light and sound, cognitive issues, like when they go to class, they have trouble concentrating, they're confused, they're just processing information more slowly. Emotional, sometimes they're more sad, more anxious, more depressed. It's a kind of a broad range. And then they often have sleep changes, that they're sleeping more than usual, having trouble sleeping. But if they have one or more of these symptoms, so just one, gets you to suspect a concussion. So if there was any hit or even possible quick movement of the head, in the sense of they went shoulder to shoulder with someone and then they developed these symptoms, then we really want to look into the fact whether they had a concussion or not. And I always like to throw this in here because this is a myth that has been around for a long time, but the myth is a head injury cannot be considered a concussion unless a person loses consciousness. And that is incorrect. It is absolute myth. The fact is that only about 10% of people who have concussions actually lose consciousness. So that does not rule out having a concussion if they did not lose consciousness. And so what do you do if your athlete has any of those signs of a concussion? They get hit in the head, they come out grabbing their head, they're a little dizzy, have a headache. What do you do? And the answer is sit out. So if in doubt, sit out. If there's any chance that they've had a concussion, we want them to stop play for that day, get evaluated by a medical provider, and then see if it was a concussion. Then we go through a gradual return to play. If it wasn't a concussion, then they can probably return pretty quickly, but they do need that medical evaluation. And so everyone always wants to know heading. Is heading dangerous? Heading is the riskiest part of soccer. This is due to athlete-athlete contact. So meaning elbow to head, head to head. It's not the ball hitting the head that tends to cause the concussion. It's the other body parts. Children do seem a little more susceptible to concussions than adults do, especially in game settings. And we don't know exactly why that is, but it's probably about how the forces affect them, that they don't have as good of technique with their movement, and maybe just that the brain is still immature and more susceptible to injury. So US Soccer has put in the protocols that if you're less than or equal to 10 years of age, you should not be heading the ball, both in a game nor in practice. 11 to 13, you can begin limited heading. And then after that, you can be heading in games and practices if you have the right form. And the right form is really important, correct heading technique. So if you look at these 2 pictures, you got the boy on this side heading and the girl on this side, hopefully you can pick out which one is heading the ball correctly. So it is the boy over here, and you can tell he's heading the ball correctly because his eyes are open. He's going into the ball to meet the ball. His neck muscles are engaged, and he is ready to direct that ball. Versus this young lady here who looks terrified of the ball. It's hitting her on top of her head. She has no idea where it is because her eyes are shut. And so this child here is not ready to head the ball. She doesn't have the confidence to do it, and so when we're training how to head the ball, it should always be with either like a rag or Nerf ball or inflatable ball. We never want to force athletes to head the ball, and we definitely don't want to have them doing heading practice where they're heading a regular soccer ball again and again and again, because that's going to put them at risk for concussion just from the quick movements of the head. Even though the ball deforms to their head, if they're not doing it right, that's still very jarring. And so a lot of people ask me about headgear in soccer. So this has become a little more popular. This athlete is wearing the classic headgear here, which is it's an impact absorbing foam layer that just kind of goes around the head, and it's designed and studied to look at head to head, head to ground, and head to goalpost. These are not to prevent any issues with head to ball impacts. They're all the other types of impacts. And it's really a mixed bag at this point as to how effective they are. There's a couple very small studies that say there may be a decrease of concussion, but it wasn't a great study because the people who participated chose to wear the headgear, and then they chose whether they would report their symptoms or not. And there was another study that did show it may decrease acceleration, so acceleration of the brain in the head. And so that could potentially or theoretically decrease the risk of concussion. And then on the other side of it, is it harmful to wear headgear? We always try to, risk benefit ratio here. And it has been shown to increase aggressive play, meaning the athlete wearing the headgear is more aggressive, also a bigger target by others. And then, as we talked about, the problem of concussion is the quick movement of the head. And if you have extra weight on it, so increased head mass, and now you have to hold it up more, then theoretically it can be harmful in the sense of having more movement rather than protecting you. So lastly, I will just kind of run through. I feel like I told you all the bad things that happen in soccer. I said how common ACL is and how concussions happen so much. So I want to just kind of round it out with all the really positive components of physical activity. So studies have shown that children who are physically active are 1/10 less likely to be obese. They have 40% higher test scores. Less smoking, drug use, pregnancy, and risky sex, 15% more likely to go to college by being physically active, ultimately have 7 to 8% higher annual earnings, lower healthcare costs, they're more productive at work, have less healthcare problems as adults, and they go on to pass this intergenerational cycle that to their children, kids of active moms are 2 times more likely to be active. So all really positive components. Some other health benefits of sports are in character development. So character, confidence, competence, connections, caring, and a lot of leadership skills, pure relationships, and self-esteem that are going to help them through life when they're maybe not as active on the field, but they can work well in teams and such. And then lastly, just looking at girls in sports, so we're looking at that specific group. Boys still seem to be having a slightly higher participation rate, 76% of boys compared to 70% of middle and high school girls play sports. But for those female athletes that do play sports in high school, 92% less chance of using drugs, 3 times more likely to graduate high school, 80% chance less likely to get pregnant, and 73% more likely to earn a college degree. So really a lot of positive benefits. So with that, just a few take-home points. Number 1, prevention is the key to ACL injuries. We're still working on all the treatment protocols, but we can do a lot to prevent. Concussion, when in doubt, sit out. And lastly, that sports participation benefits really do extend far beyond the field and probably worth the risks of some of the injuries that we described. So with that, I really thank you for your attention today, and I leave it open for questions and comments. I have my email on there, so feel free to email me with questions after. And there'll be links on the website listed here to some of the FIFA 11 work, as well as some of our other material. So I look forward to hearing some of the questions now. Thank you again.
Thank you, Dr. Zaslow. That was extremely helpful, and I appreciate you going through that. And I think it's something that we all need to be mindful of, especially as we are incorporating that and as we look to spring seasons and whatnot. So again, if you can place your questions in the Q&A box here, we will get to those. But I guess my first question for you is, we've gone all through this, and you've said that you've seen ACL injuries, go in the younger set, just like we've heard about that with elbows for baseball with Tommy John and stuff. So when should all of this be incorporated? At what age do you think a version of FIFA 11 plus should start in practice?
I mean, it can start as young as 7 years old. So the FIFA 11 plus kids is designed for your 7 to 13-year-old population. So to me, the earlier you start this, the better, because they develop the strengths and the movement mechanics that tend to worsen as they get older. So if we can have the building blocks in place, that just makes that process easier as they mature and grow.
And I know you mentioned this briefly in one of the slides about hormones and ACL injury. What is that correlation? How does that affect that injury?
Yeah, there's been some studies. It's not, I feel like it hasn't been teased out as well as it probably could, or maybe it just isn't as big of a role, but there's some role of estrogen and the timing of the estrogen rises in a female menstrual cycle that in that ovulatory phase, so when the ovulation stage occurs, that there's a small, that window has been shown to be a little bit higher risk for the injury. It probably has something to do with the estrogens that do cause ligaments to be a little bit more loose or more lax. And so that may be what's putting the young athletes at risk.
So, I was going to say, if you want to stop sharing your screen so they can actually see you
Sure.
a little bit better, that would be great. Awesome. And I guess also, going back a little bit to when we start this integration of ACL prevention and learning that, do you think that anything in the lack of fundamental motor skills contributes, the kind of that progression at an early age contributes to where we see athletes now in that? And how do we, because that's different than doing the FIFA 11, but what are some things we can have coaches or we integrate into programming that helps develop that FMS?
Yeah, I mean, some of it really is integrated through the FIFA 11 plus. Like, it's a lot of exercises that are both strength but also movement based, and all of these programs have also been shown to be most effective when a coach or a knowledgeable sideline advisor can actually give feedback to the athletes. So we don't want them to just blindly go through the program, but to actually have feedback. So I think practicing a jump, practicing the cutting, practicing a lot of these maneuvers, but with the feedback of an educated helper to give that feedback back to the athletes so they can work on making the change.
So speaking of that, what do you recommend the duration of the FIFA 11 plus sessions be within practice and also across the season? Like how many weeks?
Yeah. Sorry, how many weeks is the question? Is that?
No, both. It's how long in practice and then how long for,
Yeah. So, I mean, I think how long in practice really depends how long it takes to keep everyone corralled and working on the right components. So there's about 15 exercises. So if you, as a coach, have it all set up and you're really confident with how to move the athletes through, and then also that the athletes learn, it's probably under 20 minutes each time. So, I mean, I think the goal would be around 20 minutes. And so for duration, in the sense of how long do you continue it? Forever. So really just using this as their warm up. So when I'm talking with athletes and who maybe had an injury, what have you, and maybe they don't have a coach that's leading the charge on this, but I say, like, you can still do a warm up with your team, but when everyone else is kind of doing a stretch and they're kind of talking to each other and maybe not really trying so hard in their warm up, you just focus on doing these certain exercises. And the FIFA 11 is just a really great structure for that. And so really just integrating that into the program is great. So to me, the warm up, before most practices is ideal.
Which is great. Yes, I think it's sometimes we just want to get to playing and we forget that if it's not warmed up, it's not going to suit us well. Yeah. So switching to, if somebody has the ACL, reconstruction or surgery, what is the recommended question of what is a recommended rehab time for teen girls after surgery? And in addition, what is the best rehab?
So really good question. So the classic answer is to give a time, but I really hesitate to give a time because it's really when the athlete has achieved the right milestones. So when you're going through a rehab protocol, you have to regain strength, and that strength needs to be symmetric on both sides. So before they should even start running, they need to have 80% muscle strength on the injured limb as they do on the uninjured limb. And so that takes a while to regain. And then once they have that, then they can begin running and then working towards cutting and such. But the biomechanics have to be ironed out. Otherwise, they end up back. And Cedars, Sinai, Kerlan, Jobe, that it's most athletes who have an ACL reconstruction are run through a biomechanics lab about 6 months into their rehab, and then again before they're cleared for play. And so the typical timeline for anyone who's not a professional athlete who gets to work on this 24/7 is probably somewhere more like 9 to 12 months. So I think we used to quote 6 months. I think I think you can always aim for the 6 months, but for someone who's not a professional athlete, it's probably more like 9 to 12 months, because the worst thing you could do is go back before you're ready and then re-tear because you didn't have the right strength and biomechanics going back.
I will speak from experience. Yes. And I actually was a Cedars patient when I had my second ACL, because it was a re-tear of my graft, and a new bone actually I received. I have a new tibia because I had to drill that out. And
Oh, wow.
I did go through that biometrics thing. And actually the timing is interesting, because the first time was, many years before, but yeah, I thought I should be ready now. And no, I wound up having to be in rehab for an additional 2 months because I wasn't showing equal distribution of strength on both legs. So yeah, it is definitely one of those things. And some of it's in your head. Yeah.
Yes. It's because there's a lot to get over with the with the comfort level of even engaging those muscles. And so so it's important to really take the time going through that rehab, and it should be a really structured rehab with a physical therapist who is comfortable and experienced working with ACL rehabilitation.
Most definitely. This question is not for you, Dr. Zaslow, but there's a question here. Just I'll answer it for everyone that's on the call. That this session being at the expos that are coming up. Yes, I don't know if Scott is on here if he wants to take that question, but the idea is that we will have a form of this type of this webinar in the live form with our Cedars friends at the expos. They are LA based. So we're looking at some alumni network, some affiliate networks out there that work with Cedars that will be able to give this, but definitely. And this is, again, just to reiterate, this is recorded and we'll be sending this all out to everybody for download, because I do think it, along with all the resources. So let me, okay. Oops. Again, just continue to put your questions in the box here. I do have a question on when I know we were talking about concussion, and when people, again, much like the ACL, is there a recommended time period? And we do have our concussion training that we make everybody go through, but what is kind of that protocol in general, do you think, that they should be passing before they're allowed to come back to play?
Yeah, so for a concussion, it's very straightforward in the sense that we have really specific criteria, and then there's a specific timeline. So the very fastest you can return to contact play would be 7 days. And the reason that that's the shortest amount of time is because we know from studies that that's how long it takes for the brain to re-equilibrate, to get back to normal. So you're at risk for a repeat if you were to get hit again in that first 7 and even up to 10 days, but 7 days if you were completely asymptomatic, that you would be at risk for second impact syndrome, where you can have a massive swelling of the brain. So everyone's really strict about 7 days. If at 7 days you have been asymptomatic for multiple days, you've been able to return to school and be able to do all your school, or in the work world and work, go back to full responsibilities, full academic performance. And then the third is a physical activity. So there's a very specific return to play protocol that goes over that really 5 to 7 days. You can start the return to play protocol with symptoms. So if you have headaches, nausea, it's okay to start. You start with just 10 to 15 minutes of walking or stationary bike. If that goes well, then the next day you can go on to 20 to 30 minutes, a little more vigorous. Third stage is 30 to 45 minutes, even more vigorous. And then the fourth stage is non-contact practice. So you can even be participating in non-contact practice as long as your symptoms are the same or better. But to be cleared to play, you need to be symptom-free. You need to be able to do all that academic performance at normal, and to be able to tolerate a non-contact practice without symptoms. And at that point, you're reevaluated by your medical provider, where they do a bunch of different cognitive tests and balance tests. And if you pass all those parameters, then you'll be cleared for contact practice. But you must complete contact practice before you can go to a game. So I always tell my patients when I see them on their first visit, please don't come back to me game day, because I'm not going to be able to clear you for the game. I'm going to be able to clear you for a contact practice. If that goes well, then you'll be able to proceed to go on to your game without issue.
Awesome. Yeah, it's like my nephew. He played football, got knocked, then he tried to like sneak back around to the coach and be like, "Hey, I'm here." And they're like, "What are you doing? Like, go away." And so, but
yes, in sports like football that have helmets, we, as the athletic trainer or other sideline medical personnel will usually hold the helmet so that they can't sneak back. It's a little harder in soccer because we don't have like a helmet to identify them by, but it's really important for athletes to be educated, as well as parents and coaches, to really know the signs, and when in doubt, sit out.
Definitely. We're speaking about all the obviously the prevention aspect of it. And a lot of these injuries are not just the biometrics, but it's overuse and a tired body. So what age do you recommend, or do you see it as recommended, that a player is specializing in one sport, which means they're going to put a lot more
Yes.
use into that?
So sports specialization is pretty much as long as you can wait is the best. So at least until adolescence. So definitely our 8 and 10-year-olds should not be specialized. And people are sometimes frustrated by that, but it's really a positive. By playing multiple sports, you actually get better at your primary sport, and we have medical evidence to show that. So you're actually only helping your performance in your sport of passion by participating in other sports. So a lot of times people are worried, oh, I'm going to get injured, or I'm going to be worse at my primary sport. But no, it just helps you. And for that overuse piece, I can talk forever on it, but the few main points on it is, number one is rest. Is make sure that you get rest days, that you aren't doing the same thing every single day, because that's just going to wear out the body. So rest, as well as different sports, is helpful. And then thinking about how many hours per week you're focused on really intense training for a specific sport. So really the guideline that is also evidence-based is not to be doing more hours per week than years per age. So for example, a 9-year-old should not be training more than 9 hours per week in that primary sport. And that also doesn't mean, okay, well, fine, we're only going to do soccer for 7 hours a week, but then we're going to do gymnastics where they go to 2 hours of soccer training, and then they go to gymnastics for another hour, and then they have wrestling on the next day. So it really should be that that we're looking at that overall picture of intense training, not just isolated on a single sport.
So how about if playing multiple sports in one season? Is that something that you see as also contributing to increased injuries?
It can, if there's a fatigue piece, or if those sports are really like overlapping in what they're doing. Cross country and soccer are, two really high impact intense sports. And so I wouldn't recommend those be your overlapping sports. But if you were to do soccer and swimming, those might be really complementary, because you're working on cardiovascular and upper body fitness in the pool, and then you've got that lower extremity work that more high impact that you're doing on the soccer field. So I think it's just being really smart with the choices, and letting kids have time for free play too. So just to go out and do their own thing is really important part of their ultimate sports participation and success.
So I have a question about what about evaluating athletes' biomechanics to determine if the risk of injury is too high for participation in a sport?
Yeah, so this is, in some respects, I love seeing patients before they're injured. So when families are worried about maybe they're not demonstrating good biomechanics, then we have lots of options in the sense of one, just evaluating their movement patterns in the office. Second would be getting into a physical therapy setting where they can do it more detailed. And then third, the most intense is getting into a biomechanics lab where they can do 3D assessments And so, I think all of those can be helpful, especially, if there's concerns. To me, again, I'm all over prevention. So, so as much as we could prevent these injuries, so if there's definitely something that a parent or a coach is noticing, then it's always great to try to address that, early on and kind of get identified. And it doesn't always have to be the fanciest 3D equipment. A lot of times just a quick video or even just watching the movements can give you a lot of information.
Awesome. I don't see any more questions in the box here. Be kind of like a last call for questions as we get to wrap it up. But is there anything else that you think is important? I mean, you've shared so much stuff, but any other like last thoughts or recommendations for people? And we'll share resources if you have any, but is there anything that you think are good places for people to read or watch or just talk about?
Yeah, so my number one, I think, like final point is sports are supposed to be fun. So we want kids, the whole point of kids participating in sports is to get out there, be active, be healthy, have a good time. And so really making sure that that's the number one and that they're not being pushed too much too early. Beyond that, I think our website can be used as a reference point. I also always recommend the California Interscholastic Federation has a lot of great helpful handouts, as well as the CDC. They're really good reference points for CDC specifically for concussion, CIF for all sorts of different health-related activities, health-related issues with sports. So I think those are good places to start.
And actually just came in. Should players consider knee sleeves or braces as preventative measures, or are they actually hindering?
So it's a good question. So knee sleeves and braces don't necessarily hinder, but it's more that they don't really do much to help. So especially a knee sleeve, it might feel good, but it's definitely not going to prevent an ACL tear. Most braces aren't going to do it either. It's really, I always say, instead of buying the brace, spend the time on meeting with a physical therapist or working with a coach and working on those biomechanics. That's really what's going to be a much better benefit.
Yeah, definitely. I think that personally, it creates kind of this false sense that you are okay, you can, and not being careful and stuff. So I just see somebody asked in the chat if we could get the Angel City players to make a video for us of some of the movements. We'll have a chat with them and see if that's possible.
Yeah, would love to make that happen. So
yeah,
we can continue conversation on that. So that would be great.
Definitely. So but no, I appreciate everybody's questions, and the information today was invaluable. Again, like I said, I'm sad I didn't have this earlier for me, because I learned the biometrics, the knees going in that collapse much too late, because that's, unfortunately was part of my issue. So, but no, we appreciate your time, and we will be sharing this within the week, and we'll send out some of those other resources. And including that is Dr. Zaslow's information for questions. And so again, thank you so much to everybody and for participating. And we look forward to continuing this webinar series, and hopefully we will have a version of this at our expos for all of you, and you'll be able to attend. So thank you again, and we hope to see you all soon. Have a wonderful holiday, everybody.
Thank you.
All right, bye.